Dow. Very excited to open and start this webinar with all of you on biologics and biosimilars, all you need to know. My name is Graham Reed. I'm chair currently of the Canadian Spondylitis Association. I live with both ankylosing spondylitis and Crohn's and have been living relatively well for the last several years on a biologic, Remicade in particular. I'm coming to all of you on unceded and surrender Musqueam, Squamish, and Tsleil-Waututh lands, what's currently known as Vancouver, and very excited to share this evening with you and with our esteemed guest, Dr. Alex Charlton. Dr. Alex and I were just remissing that the last time that we spoke and saw one another in person was in late February, and it feels like an extremely long time since we were able to travel and see one another. And so on behalf of us at the CSA, I hope all of you and your families are safe in these very bizarre times. And we at the CSA have been doing a series of these different webinars over the last 7 months or so. It's bizarre to say that it's been 7 months, but it has been. And many of this is up on our website. So in addition to the session today, there are other resources on our website that many of you can access. Tonight, I'm going to introduce my panelist, our kind of keynote speaker, as we roll through the session. I'll provide a little bit of an overview on what the CSA is and then turn it over to why you're all here. Alex graduated from the University of Alberta with a Bachelor in Pharmacy, as well as a doctorate in pharmacy. She works currently at the pharmacy clinic as a pharmacy clinic practice leader at Alberta Health Services in Calgary. And also has her own clinical practice with the Division of Rheumatology at the University of Calgary. And we're very blessed and privileged to have her sharing our kind of virtual space with all of you. You know, there's a few things that I kind of traditionally go through. We're grateful for our partners and our sponsors that help us put on events like this, and grateful for Wendy, our executive director, and Dan, who's running our IT today. As I mentioned, I'll give a little bit of an overview of the CSA, stop and then let Alex share her presentation, and then Wendy and I will moderate the discussion at the end of the session. We're here probably for about an hour and a half, so looking forward to kind of maximizing the opportunity with all of you. So who are we? What is the CSA? We're the National Association with the sole purpose to support those diagnosed with spondyloarthritis. We're federally incorporated as a not-for-profit corporation. We're looking and hopefully soon to pursue our charitable status as well. Our board is comprised of volunteers living with or affected by spondyloarthritis. Almost all of our board members live with one of the various conditions of spondyloarthritis, ranging from ankylosing spondylitis to psoriatic arthritis and everything in between. So we are intending to support and provide resources for the spectrum of those different conditions. As I mentioned, we do have an executive director, Wendy Gerhardt, who's here with us, as well as international partners. One of the things that we've been doing over the course of the last year or so has been kind of revitalizing and refocusing the work of the CSA on a kind of new mission and strategic plan. And so I'd invite many of you to look at our website and look at our strategic plan, the kind of direction that we're looking to develop in, oriented around our mission being the leading voice for the spondyloarthritis community in 4 main areas: support, education, advocacy, and awareness. And those 4 things make up our strategic pillars, being education and information, advocacy, awareness, and support. I'll talk in each of those in a little bit more detail. Awareness, we're extremely excited for the number of people who have signed up for this webinar, as well as our other webinars. So one of the ways to support awareness is through social media, through community support, and I'll talk about that in a little bit. Our information sessions that normally are in person, and we're shifting to react to the times currently that we're all experiencing. We have awareness and partnership with different professional associations, whether from the rheumatology community, for the research community, or from allied health professionals. And we have a emerging CSA well recognized and reputable and credible brand that enables us to support those living with spondyloarthritis. We do advocacy and research. At that meeting that I mentioned when the last time I spoke with Alex, was also the first time that the CSA has formally supported research. We supported rheumatological research with an emphasis on patient engagement and spondyloarthritis. You can probably hear my dog, as many of us are probably experiencing, either with animals or children. And I want to just acknowledge that everybody's welcome in our circle. We work a lot on access to medication, devices, and services. One thing in particular that's relevant for this conversation tonight, and also shaping policy and making other advocacy-related activities. What one of our, I guess, main activities or kind of bread and butter is our support groups. When I joined the CSA about 3.5 or 4 years ago, there was only Hamilton and Toronto. We've now grown that to over 13, ranging from in Ottawa, where I was earlier located, to Calgary, to Mississauga, to everywhere in between, and want to acknowledge all those on the line who are either participating or leading our different support groups. This is an important avenue for us to kind of share peer-to-peer experience. No one knows better than those living with a similar condition. So make sure that you reach out to us if you're interested in joining any of those. We've piloted a few virtual sessions over the course of the last several months, and they were quite successful. So we're looking to maintain that as well, not only in COVID times, but also more broadly to support those not in large urban centers. And so definitely something, if you're interested, reach out to either myself or Wendy, and we'll be happy to either connect you or support you in starting your own support group. Upcoming events, we have a fairly busy fall that builds off the momentum of this session tonight. On October 19th, which I guess is almost 2 weeks to the day, we're having a session on psoriatic arthritis, just an overview of the disease and how to management with Dr. Chandran, a extremely reputable rheumatologist that we have a lot of experience and support from at the CSA. On November 3rd, we have a session about managing pain in inflammatory arthritis, and that is with Dr. Max Sun. Both of those you can register on our website, and we look forward to having you there as well. One important caveat that I think we always try to make is just that we are providing information, not necessarily medical advice, and encourage you to reach out directly with your own healthcare provider to discuss the things that we're sharing here or that are on our website as well. Many of us just have lived expertise, like myself, and we want to make sure that we maintain the integrity of your relationship with your healthcare team, the nexus of care that many of us navigate, and that has been even more difficult in COVID times. So with that, I'm going to stop and stop sharing my screen, and then invite Alex to provide her presentation, look forward to the questions and the conversation, and look forward to having many of you potentially participate in our support groups or other events that the CSA is running. So Chimigwech and Alex, I'm going to turn it over to you.
All right. You can see it okay?
Yeah.
Okay. So yes, thank you, Graham, and thanks to the CSA for giving me the opportunity to speak to you tonight. I always find webinars harder than if you were in front of me, but I'll just pretend. So tonight I'm going to talk about biologics and a few other things. You'll note I didn't put biosimilars in the topic because it's always important to remember biosimilars are biologics. Not all biologics are biosimilars, but all biosimilars are biologics. Uh-oh, now I've got a frozen screen. Hang on, there. Disclosures are right here, nothing really relevant to this presentation. My outline tonight is to talk about what are biologic treatments and what treatments are on the horizon. What are the biosimilars and how do they differ from other biologics? What are the biosimilar policy changes and why were they implemented? How to talk to your rheumatology healthcare professional about medication options. And then what should you expect from your medications when you start or change? So biologics are formally known as biologic response modifiers, and they are a wide range of biological proteins. They're produced in living media, so cells of either animals or plants, fungi, things like that, and they affect a natural biologic process. So there's 3 different kinds typically. One are ones that have been around for many, many years. The first real biologics, which are mimics, that would be insulin. They're usually hormones or sometimes anti-inflammatory cytokines in the case of a medication called anakinra, which we primarily use in gout and occasionally in rheumatoid arthritis. The most common type are antibodies. So they're antibodies against a cell or a protein. So any drug that ends in MAB is a monoclonal antibody. So anything with AB at the end is some kind of antibody or a piece of an antibody that performs the same function. And if any of you were watching the news pretty much all weekend, it's also what Donald Trump received for COVID. So it's a combination of 2 different antibodies that were made in a lab against COVID. And the other one is fusion proteins. So they are a biologic protein and they act as a receptor for a cytokine or some other molecule. And an example here is etanercept. Another one is abatacept, which is used for inflammatory arthritis of various kinds. So biologic DMARDs, as I mentioned, they're antibodies or similar proteins, and they do act just like the ones that are in your body from illness or vaccines. So when you have a virus, bacteria come into the body, your body makes antibodies against those. They kind of attach to them and take them out of the system. It's a very specific action, which makes them well tolerated. So things like methotrexate, cortisone derivatives, other kinds of immunosuppressants, they're not particularly specific. They kind of dampen down the whole immune system, whereas biologics are very kind of selective in which part of the immune system that they're attacking, and they leave the remainder of the immune system available. There are many different kinds of biologic medications, and they're used in many common diseases. So things like cancer, that's kind of all the new fancy-dancy therapies are biologics for cancer. Things like asthma, multiple sclerosis, and many, many more. One of the things that has to be remembered is because they are a protein, they all have to be injected in order to work properly. if you were to take them orally, then your acids in your mouth and in your gut would just degrade them. So that's why they have to be injected. We have to bypass the whole gastrointestinal system. And they may be used alone, and often in ankylosing spondylitis, they are used alone more often than in things such as rheumatoid arthritis or psoriasis and psoriatic arthritis. So there are many, many steps in making a biologic or a biosimilar. And in order to understand what a biologic or biosimilar is, you kind of need to know the process of making one. So the first one is really the longest piece, and that's trying to find the DNA that you want to act in the way that you want it against the particular cytokine that you want to work on. And then you also have to engineer those specific cells that I mentioned in order to create that protein. These cells are then frozen, and then they're kept in a bank for future batches. So each batch of a biologic pulls some cells from that original set of cells. The cells are then grown in larger and larger bioreactors. So they start with just a few, and each bioreactor they go through, it makes more and more and more until there's enough to make large batches that are able to be made into a drug and sent around the world. The proteins are then removed from the cells, and all traces of the cells are removed. So anything that you're getting and are injecting has all traces of any of those cells removed as much as possible. And then each batch, whether it's a biosimilar or whether it's an originator biologic, is then subject to quality assurance testing. So they're compared to the original reference batch for potency, which is the strength, their conformance, which is how much are they exactly like, how much they look alike, their purity and stability. And if they fall outside of those parameters that are created when the drug is first made, then that batch is scrapped and they move on and start another batch again. Finally, the last process is to add stabilizers such as sugar. There's no preservatives, no chemical preservatives, things that you might think of for other drugs. The main components are sugar, and that's what mostly keeps it from bacteria and stuff like that. Also keeps it suspended in the solution. It's also not the same pH as your body, so it uses a combination of acids and bases in order to make it as close to your own body pH as possible, and that helps to decrease the sting when it goes in. And an amino acid. So it can be any of the amino acids that help to make up DNA, which is what all cells are made of. And it just prevents, again, like I say, the drug from coming out of solution, or what we call denaturing. So if a biologic is ever cloudy, it means it's become denatured and that protein has come out of solution. So also, in order to understand sort of what biologics and biosimilars are, you kind of need to understand sort of what's happening in the body and where these work. So in the case of spondyloarthritis, we have a meeting of cells. So what happens in the body is there are lots of cells whose job is really just to travel around and identify things that are foreign. Or in the case of an autoimmune disease, there's something there that has triggered your immune system to identify your own tissue in that way. So when these cells come together, the dendritic cell, which is what's sort of the hunter cell that's going around the body looking for foreign things, attaches to a T cell, that then becomes activated and starts the whole inflammatory cycle, which at the end leads to bone overgrowth. It can lead to cartilage destruction, bone erosion, enthesitis, which involves the tendons and ligaments and where they attach to the bone, synovitis, which is inflammation of the joint, and cutaneous lesions, particularly if you have psoriasis rash. You can see here, there's a whole bunch of weird little abbreviations. So you've got cells. The Th1 cell is really just another type of white blood cell, as are macrophages and Th17 cells. So all of those cells become activated and they release different proteins known as cytokines. Cytokines are really the biggest target of most of the biologics. So we can have them where they affect sort of that attachment where those cells first come together. It can attach on here. So that's ustekinumab. So it works on IL-12 and IL-23. It can affect TNF, and that's a lot of the different ones. So we have 5 plus all of the biosimilars. So etanercept, adalimumab, infliximab, golimumab, and certolizumab. And then finally, we have IL-17A, which is secukinumab and ixekizumab. And they're the newest ones, but they've still been out for quite some time. And they're kind of whereas TNF is early on and it works well for all different kinds of diseases, IL-17 in this cascade kind of happens near the end. And by targeting it, you're able to be very specific. And we see that in other diseases like rheumatoid arthritis and some of the other things that TNF inhibitors work for, the IL-17 inhibitors don't work for. So they're much more selective to the inflammation that's involved in psoriasis, spondyloarthritis, and other types that are similar. So this is my own not very artistic shot, but it kind of, I never could find anything that really described it very well. And I'm obviously not a graphic artist, but there are several different places that a biologic can work. So like I mentioned earlier, 2 cells can come together, and when they come together, they release cytokines. Or you can have those cytokines that are released attached to a cell and release different cytokines. Biologics can work on any of those. So it can attach to the receptor on one cell, or it can attach to the cell that's attaching to the receptor on the other cell. It can attach to one of the earlier cytokines, which in this case is most likely going to be TNF alpha, or it can attach later on to some of those cytokines that are released late in inflammation and are the ones that are kind of responsible for that end damage. So a little bit about TNF inhibitors, and there's a lot of them. You can see that some of the generic names like infliximab or etanercept have several brand names after them. So those are the originator first, and then the different biosimilars. They have a long history of effectiveness. They work in psoriasis rash, in psoriatic arthritis. They work in iritis, uveitis, except for etanercept, and that's really because it's not an antibody. It doesn't have the same penetration into tissues as the ones that are antibodies or pieces of antibodies. It works in ankylosing spondylitis and inflammatory bowel disease, so both ulcerative colitis and Crohn's. And again, for the same reason, etanercept doesn't really work for inflammatory bowel disease. So if you have other comorbidities, which is common, so a lot of patients with AS frequently have different forms of inflammatory bowel disease. Pretty much any inflammatory disease can have uveitis involved, but it's most common in AS as well. So these are drugs where there's multiple things rather than just a joint involvement that may be considered. There's good evidence they improve all symptoms of disease. So radiographic progression, tender and swollen peripheral joints, axial disease, dactylitis, which is the sausage fingers and toes that we may see, enthesitis, which I spelled wrong. Oh no, I didn't. And skin and nail involvement if you have psoriasis rash. All of them are similarly effective, except for, as I mentioned, etanercept. And etanercept and certolizumab seem to have a longer time in the body before you might need to switch to another one. So not in everybody, but in most people at some point, the body becomes used to biologics. So either you build antibodies against the drug itself, or the body finds a way to create inflammation by a different method. So most biologics last in the body about 5 to 7 years before it starts to not work as well. Fortunately, people who have spondylitis don't seem to have the same sort of time that it takes as in something like rheumatoid. So rheumatoid arthritis patients tend to make antibodies a little bit quicker than those with AS, and sort of psoriasis and psoriatic arthritis is kind of in the middle. But etanercept and certolizumab, because they're kind of unique in how they're made, the immune system doesn't really recognize them as early, or there's some other mechanism that allows them to have more of a time of 7 to 9 years before we might need to switch. But there's wide variances. Sometimes people need to switch after a couple of years. Others, we have some patients, not very many anymore, but we do have some patients who were on the original trials for adalimumab and infliximab back almost 30 years ago now. Differences really are related to onset of action, patient convenience. So there's certain things like, are they stable at room temperature if you travel a lot, things like that that are different. May also be if a female is trying to get pregnant, there may be some that are preferred than others, and lots of other patient-specific factors. Infection risk is greatest in the first 6 months and is greatest with the TNFs compared to the other drugs that I'm going to be talking about later. And again, that's kind of just because it happens earlier. Blockade of TNF is earlier in the inflammatory cycle, so it affects other pieces of the immune system. The greatest infection risk, again, is for 6 months. Those who are on corticosteroids as well, so not just a shot in a joint or an occasional Kenalog injection, but those who are on long-term steroids or higher dose steroids. Patients who have lung disease, kidney disease, diabetes, and older age. Otherwise, TNF inhibitors are well tolerated. Monitoring is often less than with traditional DMARDs, which is nice for people. It doesn't affect the liver, it doesn't affect the kidney. In fact, biologics kind of bypass those altogether and are removed in the same way that the body removes antibody virus compounds, virus or bacteria and antibody compounds, etc. You don't have to monitor the blood counts, you don't have to monitor the liver function like you would unless you're on like methotrexate or leflunomide at the same time. It's also drug of choice in those who are pregnant. So certolizumab, etanercept in particular, they don't cross into the placenta as easily as the other ones do. But even those that do cross into the placenta, we know that those are safe and effective as well. IL-17 inhibitors, as I mentioned, are kind of the newest ones in the block. Secukinumab and ixekizumab, I have a hard time with that one. They've been shown to have similar efficacy to the TNF inhibitors for peripheral joints, lack of radiographic progression, the dactylitis, enthesitis, and the spinal disease. They've also showed effectiveness in patients who previously failed a TNF inhibitor for both psoriatic arthritis and for ankylosing spondylitis. So that's always nice to know. Those who have failed even multiple seem to be able to respond to these drugs. There's also less viral and bacterial infections compared to TNF inhibitors. IL-17 seems to have more of a role in preventing and getting rid of fungal infections than it does for bacterial and viral infections. For those who also have psoriasis skin lesions, these both actually outperformed etanercept and adalimumab for the skin disease. So they work better for psoriasis skin disease. They can't be used in patients with inflammatory bowel disease as it has no benefit and potentially can cause it to worsen. It also doesn't appear to treat uveitis optimally. At high doses, there have been studies to show that it does work well, but in the lower doses, it's kind of, sometimes it does and sometimes it doesn't. So there needs to be more of a study looking at what types of patients that it may be helpful in and what the dose might need to be in order to see benefit for uveitis. There's also no current evidence for use in pregnancy. And then finally, ustekinumab, which is an IL-12/23 inhibitor, has some similarities in the pathway of the IL-17 as well. Ustekinumab has some limitations in coverage. So here in Alberta, unless somebody has psoriasis rash and the dermatologist orders it, we have a lot of difficulty getting it. We may be able to get it from the company, but through insurance, like governmental insurance, it's really quite restricted to us. And most of our patients do have at least partial coverage through our Alberta program. And around the country, it's a little bit different. The IL-12/23 are important stimulators that actually turn those early T cells into inflammatory cells. It has indications for psoriasis rash, psoriatic arthritis, ulcerative colitis, Crohn's, but not AS, not here anyway in Canada. Small studies do show effectiveness for axial disease, and it may have some benefit for uveitis, but it doesn't perform as well as TNF inhibitors for joint disease, which means there was less patients who reached the 20, 50, and 70% improvement, which is kind of the standard. Whereas the IL-17 inhibitors, they were equally effective. It also didn't work as well for enthesitis or dactylitis. But there is inhibition of radiographic progression of joint damage. And like the IL-17 inhibitors, there's less infections than seen with TNF inhibitors. And I thought I would mention a newer drug called JAK inhibitors. Now, these are a little bit interesting in that the two previous ones, tofacitinib and baricitinib, did not seem to have much benefit in spondyloarthritis. However, recently, very recently, February of this year, a study was published with the newest one called upadacitinib, and it did show benefit in AS. So they are going to be going for an indication for AS, and hopefully that will be available, because the really nice thing about JAK inhibitors, much like the TNF inhibitors, is that they're effective for not only spinal disease, but uveitis and bowel disease if that's present as well as skin disease. They're also oral. So for those of you that are a little bit nervous to take injections, they're either twice a day or most of them are available in daily formulations. And they have some similarities to biologics and to traditional DMARDs. So there's infection concerns similar to mostly TNF inhibitors, but there's a particular increase in the development of shingles. Gastrointestinal side effects tend to be mild. There's also a few interactions, but they're typically pretty easily managed. So in that way, they're similar to the traditional DMARDs, and we do have to monitor blood count and liver function tests, just like we do with the traditional ones. And as I mentioned, there may be some benefit in uveitis, but right now that's just animal models. And this is a little bit sort of a combination of my bad graphics and actual graphics. So in that sort of final step where some of the cytokines that cause that direct inflammation and damage are released, what happens is something like TNF or another one of those intermediate ones attaches to the cell, and it releases a whole bunch of different steps that eventually lead that cell to release those final cytokines. So what a JAK inhibitor does is, instead of allowing the cytokine to attach, it attaches to the receptor. It's then brought into the cell, and that cell actually can't be made into a cell that can make inflammatory proteins. So the sort of end production of those cytokines that cause the inflammation and damage are stopped. And that's why there's some similarities between them and traditional DMARDs as well as biologics. And I'll just show this one study that, like I say, was pretty recently released. It was 187 patients who were randomized to the drug and 94 who were in the placebo. And there was an assessment at 14 weeks, which is quite early, but there's another study going on that is an extended time period that will look at it. So in a lot of the different ways of kind of identifying how well it's working, it was better, significantly better than the placebo. And that was different, like I said, from the other two JAK inhibitors that didn't do as well. But one of the most important things here is that on MRI, there was a lot of benefit. And that's a big one because it identifies even the smallest changes. All right, now I'll get into the biosimilars. So biosimilars are not bioequivalent to their originator, meaning that a pharmacist can't switch back and forth. So Health Canada kind of determines which drugs are considered equivalent and can be switched one for another without really having any difference in activity or in end result. Because these aren't considered bioequivalents, only a physician, at least in Alberta, only a physician can order them, and they order one, and the pharmacist can't swap between them. So once you're on a biosimilar, you stay on that biosimilar until your physician changes it for whatever reason, whether it's intolerance or it's just not working anymore. Generics, however, though, can be switched back and forth numerous times. So pharmacists will order one brand 1 month and potentially another brand another month if there's a shortage of the previous brand, and you can switch back and forth. And there can be a lot of differences in the generic brands back and forth. There's actually less differences in the brands of current biosimilars than there is with the typical generics that most of your drugs that you get in the pharmacy are for. Because they're made by living cells, the end product can differ with each brand and even within each batch. So in fact, if you were on Enbrel, the Enbrel that you had 20 years ago, 10 years ago, is not the Enbrel that you have now. In effect, they're biosimilars of each other. So each brand can be different. The manufacturing differences in each brand, but also if there's manufacturing changes between batches during the course of the drug's lifetime, those would be kind of considered similar to biosimilars. For true biosimilars compared to the originator drug, they have to show similarity to all the parameters of the original. They also have to have clinical testing to make sure that it's working as well in certain populations. Now, the studies aren't as large as they are in the originators, but they still need to show that they're effective. Also, as I mentioned, there's slight differences in sort of the additives that are in the product. Again, they're not preservatives, and they tend to be quite similar. So it will contain a sugar, perhaps in one it's glucose. In one of the biosimilars, it might be fructose or sucrose. We'll have an amino acid. It might be G in one, and it's a glutathione, or it might be A, which is adenosine in another one. And again, it's just a stabilizer that helps to keep it in solution. There's a salt to increase the pH. Often it's sodium bicarbonate, and an acid to decrease pH. So you may have heard of Humira citrate-free. So there's a new one available in the US, but not yet in Canada. it's been approved in Canada, but not available. And it doesn't use citric acid. It uses a different acid, which doesn't sting as much. Humira is kind of well known for stinging when it goes in. And again, it's important to know they don't contain any chemical preservatives. So people are always worried they have sensitivities to certain preservatives, that there might be changes from brand to brand. But any of the changes here really shouldn't have much of a difference patient to patient, except how it feels, or perhaps the stability, such as Erelzi is 60 days versus Enbrel is 90 days at room temperature. So this is just a little scheme of how these biologics and biosimilars are approved. So there's actually an extra step in approving the biosimilars than there is in the originator. So all of the same things really are included in the biosimilar as in the originator, plus there has to be comparative non-clinical clinical studies as well between it and the originator drug. Where I mentioned that each batch can be different, but also each company's own drug can be different. Because of how the drugs are made, you can't control what happens in a cell. The cells kind of do their own thing independent of all the different things that we do. We try to make them as similar as possible, but in the end, there might be some biologic variability. And really, oftentimes it's that perhaps one of the pieces that make up the DNA might switch places. So as I mentioned, there might be an adenosine and a glutamine that might switch places, but has no real effect on the endpoint. Or the most common one, which is production of these little side chains. So you can see that the drug is exactly the same, the reference medicine and the biosimilar, but these little changes happen in the cells that just add these little carbohydrate chains onto the molecule. It can also affect how the molecule folds itself up. So that's why they're not considered exactly the same like a generic drug is. As I mentioned before, biologics change over time. It's not possible to demonstrate that a batch of any biologic is identical to its previous batches. But the important thing to know is that these changes aren't typically clinically relevant, meaning the patient doesn't usually notice any different. There's the odd time perhaps that a patient may feel like, there's not quite as good effect of this batch as when I had it the last few months. That may be a little bit that you do notice a slight difference, and that would be kind of the difference you might notice switching brand to brand. Also, throughout time, there may be changes in manufacturing processes, and that's because the technology of making these has changed so much. They went from being very rare to being very, very commonly used and used for all kinds of things. So it makes sense that a company would want to alter its process if it can lead to a better end product or can increase efficiency or something like that. And again, a lot of the difference is really in those side chains that makes a difference. So batch one is sort of known as that originator reference one. And then the next batch, the batch following that, they're all slightly different, but they don't have much effect. If they do have a lot of differences and there's strict parameters around them, then as I mentioned before, they're thrown out and new batches are made, and any adjustments that need to be made to the process are also made to try to prevent it from happening again. You can see here, this is where I was talking about batch to batch differences. So this is American Enbrel, this is European Enbrel, and this is one of the biosimilars. So you can have differences no matter which type that you have. And this is just the range, and it's the amount of activity that the molecules in the batch have. And this is also what I was mentioning with changes to how it's made. So perhaps with infliximab, you can see over its lifetime, which the trial started in, I think, 1995-ish, there's been 50 changes. So only 3 of those were noted to be of high risk, meaning whatever that change was scrapped because the end product was too different. Same thing with ustekinumab in its sort of shorter lifetime, there's been 9. For Symphony, there's been 13. For Cimzia, 15. So there's lots of these changes that occur and differences batch to batch that you don't even notice. That we know of, only 1 has ever resulted in an adverse event, and that was actually related to the what it was kept in. So the syringe that it was kept in was actually the problem, but that's the only one that's ever been removed because of a major problem with the end product in actual use. So why does everyone want to change? So last year, BC was the first province that initiated a change over to biosimilars. Alberta followed suit this year, and we're right in the middle of it right now. All of our patients on Enbrel and Remicade have to change to a biosimilar by January 15th. Rituximab is also having to be changed in the same time period. That's not a drug that's used in spondyloarthritis. But the other big one is going to be Humira, which will be switched starting about February, March of next year is the estimate. And there are 6 biosimilars that are available, unlike Enbrel, which has 2, and Remicade, which has 3. But you can see that we need to manage the costs of these drugs. So this is looking at 2018. So that's the early, or the soonest one that is available. There's nothing for 2019 or for 2020. And we are 5th. So 26.2% of all our drug costs is just due to biologics. And it's a very small percentage of all the drugs that are available. And over here, looking at in comparison to the amount spending per capita on the biologics, the US is the highest by a lot. And that has to do with their free market system, and all the rest of these are a controlled market system. But we're second, whereas some of these countries like Korea and Sweden and Poland that have been using biosimilars for many, many years effectively, they're way, way down in the cost of medication or of biologics. These are Alberta numbers, and I'm just going to show you sort of the difference. This is based on the Alberta Drug Benefit List, which is the amount that the government will pay. So the biosimilars are about half the price. And same thing for Remicade. I don't have the newest one on here because it wasn't on here when I made the slide. It's newly available, but you can save a significant amount of money. So for 100 patients who are on biologics, assuming 39 of those patients are on infliximab and 15 of those patients are on etanercept, we're able to save a lot of money. So $577,000 for every 100 patients that are on a biologic for using Renflexis or another biosimilar. And if we switch for the 15 patients to a biosimilar of Enbrel, we're saving another $125,000 for a total of about $702,000. For that same price, 56 people could be initiated and treated for a year on the biosimilar for etanercept. 45 people could be treated for a year with one of the biosimilars for infliximab. And 36 people could be treated for 1 year with Orencia, which is not available. It's a drug for rheumatoid arthritis. And 40 people could be treated with the Xeljanz, or the JAK inhibitor Xeljanz. So what this really means is that by switching people to a biosimilar, we're making more room in the drug savings available that can then go to originators. If people aren't able to have their drug covered, then over time, the drug companies will quit looking for new ones in the same area because they know that people won't cover them. So if we can get the overall costs down, it makes it more likely that newer drugs will come to market. There also may be a bit of insurance differences, and mostly that difference is just there's not a lot of extras. So some of the larger originator companies, they offer a lot of sort of extra supports that some of these smaller companies that make the biosimilars just can't. Other thing that might be affected is if you're on sort of infliximab in particular, it might affect your infusion center. So if you are switching over and you're on an infusion, it may be worthwhile to find out which of the biosimilars uses the same infusion center, and then at least something isn't having to change. But generally speaking, most people get the same kinds of supports as they had before. So what's the evidence for doing this? So there's lots. This is just sort of one of the big ones. So this was done in Norway. It's called Norswitch. And it was done in lots of different patients with lots of different diseases. So 482 patients who were on the originator were then, half of them were switched to the biosimilar and half stayed on Remicade. Eventually, after a year, those remaining patients who were on the originator also switched to the biosimilar. And what the end result was that you can see there's very little difference in benefit between the biosimilar and the originator. In the end, often these either cross over or they meet right together. So really there's no clinical difference in all of these between the originator and the biosimilar. So this plus many, many more confirming studies give us great comfort in being able to change without really any change in clinical effect. So the bottom one is disease activity score or index, and this one in particular is the ankylosing spondylitis disease activity score. And in fact, most of the problems that were identified with switching were due to something called the nocebo effect. So when the researchers looked at the objective evidence, there was little difference between what they started with when they switched from the originator to the biosimilar, but patients felt that they weren't doing as well. And that's what's known as the nocebo effect. So placebo effect is where you think something is an active drug, therefore you think it works. Nocebo effect is where you think that the new drug isn't as good as the old drug, and your brain is so powerful, it makes it feel like you're not doing as well. Finally, we'll go into a couple of just general things, what to expect from your medications. One is that medications need to treat all your symptoms. So if you have psoriasis rash and psoriatic arthritis, you need to make sure that both are being treated. Same thing if you have ankylosing spondylitis and you have IBD as well. We want to make sure that we have a drug that's treating both. So in that case, maybe we throw out the IL-17 inhibitors. And same thing with SPA and iritis or uveitis. We need to make sure that we're covering all the symptoms when we're determining how well a drug is working. Medications take time to work. So JAK inhibitors work very quickly. Some of the studies show that there may be a difference in as much as a week. Biologics, it's highly variable. It kind of depends on a few things, whether or not there is a loading dose, how long what we call the half-life is, so the time it takes for the drug to leave the system. All of those kind of make a difference. Generally speaking, a biologic starts to work at about the 3rd dose, and it can take up to 3 months, so however many doses of that particular drug fits in before you get a full benefit. And that's more like the traditional DMARDs, but those usually take at least 6 to 8 weeks to start working and 3 to 4 months for full effect. I want to consider combinations of drugs. So often we'll use drugs with different mechanisms of action. So methotrexate and a biologic are common because not only does it kind of have 2 different mechanisms of action, but adding methotrexate actually decreases the likelihood that your body will make antibodies to the drug or that the drug will become less effective over time. That's a big reason why we use the 2 together. Also, you tend to get less side effects when you're using small amounts of multiple medications rather than high doses of one. In some cases, there's not a lot of evidence to do this, but in our clinic, sometimes we will keep a patient on, say, a TNF inhibitor if it's working for their joint and spine symptoms, but if their IBD is flaring, we might use one of the new biologics that's selective right to the tissue in the bowel and doesn't have an effect on the rest of the system. Also, you want to make sure that you have something for flares. So even the most well-controlled patient often will have the occasional flare, and that's where you would use other medications like anti-inflammatories or Tylenol or whatever else you have that may work for you. The other thing that's important to remember is the probability of it working. All drugs work about the same. So if you look at all the different studies, about the same number of people have a 20% improvement, have a 40% improvement, have a 60% improvement. So the likelihood that any one drug is going to work is about the same. And as I mentioned before, those medications may stop working. But if you responded to one in the same class, there's a high probability that you'll respond to another one within the same class. The question that was asked that I just cover is how to discuss medications and medication changes with your doctor. I'm going to switch it to be healthcare professional because this is where most of my referrals in my clinic come from, is patients who have a lot of questions about their medication and are trying to decide what the next best step should be. So the most important things I could think of are to educate yourself. If you just kind of storm in and say, I read this on the internet, it might get people's backs up a bit. If you're going to go in and you're going to read stuff, go to reliable sites. Try to avoid complaining blogs where most people are just complaining about their side effects. What I kind of look at this is people who are doing well and are out and living their life. They don't have time, nor do they usually have the inclination to go on a site and tell everybody how wonderful it is. It's kind of like if you get bad service at a store, you're more likely to go on Google and complain about the place that you got bad service than you are at the 50 other places you had fantastic service. University or organization sites are great. So if it's some major organization, those are usually very reliable. Lots of summary sites like Rheumatology Advisor, MedPage Today, Medical Page Today, where they summarize in pretty close to layman's terms, but certainly easier to read terms, different studies, and kind of go through certain topics that are helpful. And if you're so inclined to know how to read a research study, that's always the best place to go. Also, make sure you're respecting their time. Most follow-ups are about 15 minutes compared to a new one, which is about 45. So in that short period of time, you have a lot of stuff to cover. You've got the exam, you've got kind of the history, everything that's happened to you since the last time you were there. So you've got to prioritize your concerns. Also, You may want to ask for someone else like myself who has more time to discuss it with you. There might be classes or webinars. At my clinic, we offer a whole range of different classes where you can talk to not just myself, but also the physiotherapist, the nurse, the one of the physicians, as well as our social worker. I don't know that's not common everywhere, but there may be something, or at least something similar somewhere that you might be able to access. Might be support groups. And the other thing that's becoming more common is, can you send your doctor an email? I know I do, or nurses do, and some of the physicians, they will respond to emails. And that's usually a lot quicker and can be done quicker for the person. Like if I'm in a boring meeting, I can just answer your email then rather than having to call separately. You also need to know what your goals are. So what is your goal? What do you want out of this? Because that's going to change the discussion. You also want to organize your choices. So if you have lots of choices and you've researched them, which ones are you most and least interested in and why? And now coming up, hopefully eventually, if the JAK inhibitors get approved, you may actually have a choice between the oral versus injectable, just like you have a choice between injectable methotrexate and oral methotrexate. And be open to recommendations. What you think you want may not be the best choice, but make sure you know why your doctor or other healthcare professional is saying that. And then finally, medication isn't everything. All of these other things go into it as well. Obesity, it has a lot of impact on how well we can get the disease under control, and it may make it more difficult to control it. And we have evidence that some medications don't work as well. Sorry, I'm going back and forth. So the JAK inhibitors in particular, and some of the biologic medications do not work as well in obese people as they do in those who are of underweight or of normal weight. Diet can have an impact. You want to make sure that your diet is nutrient rich, particularly in these ones listed here. Often those are the ones that kind of get missed, especially if people are taking a lot of things out of their diet. Want to make sure you avoid sugar, processed sugars, and high fructose corn syrup. They've been known to promote inflammation. Got to make sure you're getting exercise as well as a healthy lifestyle. So that's really everything I have. So just in summary, we have 3 different classes of drugs that are all effective in peripheral and axial SpA, but their efficacy in other comorbidities differs, and so does things like infection risk. Other targets in the cascade are being developed. So when I first showed that original picture, there's lots of targets there that still haven't really got any biologics out and available. So there will be more things coming out in the future. Process of making biologics and biosimilars is complicated and unpredictable. Each batch and brand can differ, but will have little impact on your clinical benefit. Years of biosimilar use in other countries where it's shown huge financial benefit, and that allows for coverage of newer drugs. Differences between brands includes not only differences in the drug, but also coverage, support programs, and infusion clinics, and needs to be things you need to think about. Medications are only part of the overall SpA experience, and also talking with your healthcare professionals requires knowledge, and this and all the other ones that are being available is a good place to start. And I guess now we can get to the questions. All right, lots of questions. So the first one, things to consider when starting biologics in the midst of COVID-19. Safety, whether to start or not, precautions. So this is a very complicated topic. But the main thing to know is that even though you will see lots of things that refer to immunosuppression, biologics are not immunosuppressants in the traditional way that we think of immunosuppressants. When a lot of those references are made, they're to things like chemotherapy, to things like high-dose corticosteroids. The biologics, they modify your immune system. And as I mentioned, there's quite a bit of difference between the biologics. So people on TNF inhibitors tend to have a little bit more impact on their immunity than either the IL-17 inhibitors or the IL-23 inhibitors. But regardless of which disease-modifying agent that you're on, newer or older, there hasn't actually been any evidence to say that you're at any greater risk than anyone else of catching it. And that's true really any infection. You're not more likely to catch something, especially a viral illness, than anybody else. The severity may be affected though, or you may be more likely to get a overlapping bacterial infection. But typically speaking, catching those diseases is not really an issue. The other interesting thing is that these medications are being used to treat COVID infections. So a lot of the most severe COVID infections are related to that overactivity of the immune system. Just like in an autoimmune disease, you have an overactive immune system that we need to try to bring down to more normal. So these types of drugs, things like dexamethasone, tocilizumab, which is a study we're doing here, JAK inhibitors, they are all being used to try to settle down that immune system response with COVID, just like they are with the autoimmune diseases. So basically, every single rheumatology association, European, American, Canadian, has come out to say that COVID or any other infection that might be going around, such as flu, should not impact starting a medication. Because you also have to remember that there's some level of immune compromise associated with active disease as well. All right, next question. I live in a small community and must fly to have in-person appointments with my rheumatologist. Oh, that's interesting. What are some strategies to help me in starting biologics for the first time when I don't have knowledgeable doctors in my region regarding these drugs? Couple things, I guess, is you must have access to the rheumatologist or someone else by phone or email, or hopefully now with COVID, video chat. At least here in Alberta, most of our physicians are doing most of their clinics by video chat. So those are options if you're obviously you're computer savvy or you wouldn't be in on this tonight. Other thing is, ask your pharmacist. They might not have the expertise in this like I do, but they may know how to contact someone with expertise, or they can look it up and work with you on finding resources. I used to work in a small town community pharmacy, and they certainly have a lot more time than those in the big city to spend and help patients to go through their questions and concerns. Are fusion protein biologics the same as IL-17 inhibitors? No. Fusion protein biologics are just the ones that have sept at the end. The current IL-17 inhibitors are both antibodies. Next question. I have AS. I'd like to hear about methotrexate, a scary drug. All of them can be scary in their own way. I wouldn't say it's necessarily more so than anything else. It's been recommended to me, but no one seems to know how much benefit, if any, it provides. Seems like word of mouth hearsay. No. What are the studies that supposedly quantify the alleged benefits of taking this along with Humira? So this is a bit of a loaded question. It sounds like you've already got your own set of mind made up. There's many, many, many years of experience with methotrexate and too many studies to name. But methotrexate in SPA typically doesn't have much benefit in spinal disease, but it's very effective in peripheral joint disease. So often that's where we would use it, is in someone who has good control of their spinal disease, perhaps with a TNF inhibitor, but maybe doesn't have full response with their peripheral joints. The other thing, as I mentioned, using it in particular in combination with Humira. So most of the drugs, there isn't a lot saying that it works better than either one alone. But for Humira in particular, numerous studies have shown that using it with methotrexate, particularly in RA, that's where most of the studies have been, but it works better than either methotrexate or Humira by itself. It also may increase the length of time that your biologic may work. So from maybe 3 years without it to perhaps the average of 5 to 7 years with it. If Humira stings, do the others not? So it's quite variable. Humira just is the one that seems to be the one that most people find stings, but lots of people don't. So if you look at the studies, anywhere from about 3% of people report stinging to about 20% of people report stinging. It only stings for a few seconds, like it stings as it's going in. But yes, Humira has changed its formulation to try to fix that by removing the citric acid. Some of the other ones are a little bit less likely, but because they're all foreign and they're all slightly off your body's pH, they may sting. Can someone go back on a biologic they stopped using in the past if stoppage was not due to the drug no longer working? Yes, but it takes a lot of effort. So usually the companies will only allow us to go back to something else regardless of why it was stopped if all the other options have been eliminated. And usually insurance will deny it at first and we have to appeal it. But pretty much we've always been successful in those circumstances if we've run through everything else and we need to fix that. What study showed the long-term efficacy remission in patients on etanercept? You talked about 5 to 7 years. So there's quite a few studies that have looked at length of time of the different biologics. And I can't name them off the top of my head because they were all done many years ago. Can you get a flu shot if you are on Taltz or Enbrel? You can get a flu shot if you're on any of them. It's important, especially this year in particular, in order to help kind of eliminate the concerns around going to work with sort of respiratory illnesses and the concern about whether it's COVID or whether it's the flu. But even in non-years like this, I would strongly recommend that you always get a flu shot. I started Humira and I'm in my second month. Will it help with my chronic fatigue? So if your fatigue is related to inflammation, then yes, but fatigue often takes a while to improve, and it's also multifactorial. So sometimes people have had a lot of pain, a lot of disability will become deconditioned, and sometimes the fatigue they experience is from that. So yes, it should have at least some benefit if it's due to the disease itself. How does taking a break from a biosimilar for major surgery affect you? So if you are just doing it for a single surgery or for a course of antibiotics or something like that, usually there's very little impact. If you end up being off for a really long period of time, there's a good chance that the drug won't work as well when you go back, or if someone's going off and on and off and on and off and on, then that can also cause the drug to kind of stop working or not work as well and require a change. You mentioned there's a particular class of drug that was safe for pregnancy. Does Humira fall into that category? Yes, the TNF inhibitors are considered one of the drugs of choice in people who are pregnant or planning to be pregnant. How serious are the side effects of using biologics? It depends on the biologic and it depends on your other conditions and comorbidities. So as I mentioned, there's variances in side effects and in infection risk, and also dependent on if you're diabetic, if you're obese, if you have lung disease, kidney disease, or on other medications. Can my GP prescribe biologics or biosimilars? No. Who does the injection? Usually we train you to do it, but if you're not able to, in some provinces, I think all, but I'm not 100% sure, a pharmacist can do it. Often we'll train a family member to do it. Biosimilars are covered by all, biologics and biosimilars are covered by all provincial drug benefits, but they have may have different restrictions. Any thoughts on supplements like vitamin D or omega-3? Might they be beneficial? So vitamin D, all people who have inflammatory joint disease of any kind are at much greater risk of osteoporosis, and having adequate vitamin D is very important there. Dr. Fauci has also strongly recommended everybody take vitamin D for COVID. Just I don't know if that really has any benefit on COVID or he just thinks that it's a good thing to take. But you can't go wrong taking vitamin D. In Canada, you just don't get enough through sunlight. Omega-3, omega-3s have some potential benefit on inflammation. It's not a disease-modifying agent, but it can potentially help with symptoms, but it also decreases cardiovascular risk, which anyone who has high amounts of inflammation may have. I have more bad days with stiffness, sore joints, and fatigue than good. Will Humira help me to have more better days with these symptoms? So if it works, optimally, yes. What the goal is to get your disease under as good of control as possible. So you may be changing medications until you find one that works the best for you. And it may be Humira, I hope it is, but it may end up being a different biologic. You just have to see how well you're doing. I failed methotrexate, but I've heard when there is substantial spinal involvement, TNF inhibitors seem to be a good choice. TNF inhibitors or the IL-17 inhibitors are equally good choice. I have AS and I've used 5 biologics and none of them seem to work well for me. How many biologics are available? So Enbrel, Humira, Cosentyx, Inflectra, and Taltz. So there's a couple of other TNF inhibitors, but if you failed 3, there's possible that you might fail that as well, but often we will try all of them if we need to. How many more biologics are available after that if you've tried those plus Cosentyx and Taltz? that would be where hopefully the new upadacitinib JAK inhibitor gets approved, and we would hopefully be able to use that in you. Do you see an added benefit for patients to see a dietitian? We see a lot of books about eating for RA, for example. Just wondering if these have some weight or if they sort of lack evidence. Most of those diets about inflammation don't have a lot of evidence. If you are wanting to lose weight, if you feel you don't have a very healthy diet and would like more information on how to do that, a dietitian would be helpful in there. Otherwise, all those different diets that come out where you're taking out things and putting things in, generally speaking, what the advice of our physicians is, and I agree, is if you find something in your diet is making your symptoms worse, stop it and see if it's better. If it doesn't seem to make any difference when you take it out of your diet, then go back to eating it. The more things you cut out of your diet, the more potential there is for vitamin and nutrient limitations and those kinds of things. It's also really hard to do. So cutting out sugar, high fructose corn syrup is probably the biggest across the board diet change, which I talked about. I think I'm at the end of the questions.
Hi, Alex. There's one more. I'm just trying to scroll through and find it. Here's a question. Why are some of the new biologics on the block better / safer for risk of infections compared to the older ones?
Because they're more specific. So we now know more about the pathways for each of the individual diseases. And by being able to break down those pathways, we're now able to get at cytokines that don't, if we knock them out, don't have as much impact on the whole rest of the immune system. It's just technology, really, and also because the TNF inhibitors worked for so many things, they had very good uptake. But I think over time, you're just going to see more and more drugs that are more specific and have less impact on other things. So TNF inhibitors in general do have more rare side effects as well. And that's again because of kind of TNF being used in all parts of the body and in the immune system.
Perfect, thank you. Hi everybody, I'm Wendy Gerhardt. I'm with the Canadian Spondylitis Association. I'm the Executive Director. I'm going to close the webinar tonight by first of all thanking Alex for sharing all of this really valuable information. I know it was a lot to absorb, and we are going to be posting this webinar on our website following the presentation this evening, so likely realistically tomorrow sometime. I also want to thank all of you for joining in. I know it's a scary time when you're trying to learn about these innovative medications and trying to decide whether you want to take these kinds of medications or not. And there's lots going on with policy changes. So we wanted to provide a forum where you could learn a lot more about biosimilars and biologics. And just a couple of housekeeping things. Want to remind everybody that we're offering a few more events this fall. Please check our website. They're listed there, and we have probably 1 or 2 more into the latter part of November that I'm sure that you'll all find very interesting. So visit us at www.spondylitis.ca and look into our events page. We look forward to hosting you at some of those events as well. And last but not least, please take a few moments to complete our evaluation. I understand that there's some problems with the link, but we'll get that sorted out right away. And we do appreciate your feedback. Really gives us insight into other programs and resources that you will find helpful. And that's what we're here for, is to support you. So please take a moment to fill that out as we look to build out our 2021 programs and resources plan. And with that, I will again thank Alex, thank all of you. Please stay safe in this COVID-19 pandemic that we're continuing to go through. We are always here as a resource. Anybody needing support in one of the ways that Graham outlined earlier, we're happy to speak with you and to connect you in the appropriate style that you want to receive support. So with that, I'll close the webinar off. And again, thank you, wish you a happy evening, stay safe, and we'll see you next time.